Thanks for the organisers for inviting me to speak, and especially to the whole Mutograph team in IARC, Paul and Estelle, who I know have been running around like crazy for the last few weeks. I'm going to talk just a little bit about the emerging etiology of esophageal cancer in East Africa, in part because I think it would be really nice to bring together the mutation signatures and the kind of conventional epidemiology, especially in Africa, where we're not as advanced knowledge as in Iran and China, and the story is just emerging because we only really started work in the last 5 years. Our work in East Africa was really initiated by and supported by Chris Wilde, our former director, and we initiated a meeting 6 years ago where representatives from across East Africa, across the African esophageal cancer corridor, as well as our colleagues from NCI and Brazil came together to decide what we should do about what research we should do in East Africa. And in this just short 5 years, there's really been a huge shift, and IARC is now leading 3 case control studies in Kenya, Malawi, and Tanzania, and they're the ones I'll talk about today. And the NCI and UCSF are also leading case control studies. We don't have huge cohorts to work on, so it is a case control design. It's suboptimal, but it's the best we can do in the timeline. So the IARC sites I'd like to introduce there, beside me there is Diana Menya, who really started the first case control study in West Kenya and has been working closely with us as an excellent lead epidemiologist on the ground. Beside her is Charles Samalala, the head of the Malawi Cancer Registry in Blantyre, and beside him, Blandine Mbaga. They unfortunately couldn't be with us here today, but I hope that you'll meet them at a future Mutographs meeting, or when we have our meetings annually in Africa, the Mutographs could come down and show some of the results. Here at IARC, the team is Joachim Schutz and Daniel Middleton. So one of the first things we did is, look in detail at the African settings and see, what are the likely exposures that might be present that have been found in Iran, China, Brazil, South Africa. What are the local specific exposure circumstances? And we're really taking a broad view and some kind of stabs in the dark. We didn't want to make kind of the mistake of, after the aflatoxin gold rush, there was there was a lot of research for many years on fumonigens, and people were putting like all their eggs in one basket, and it hasn't come to much. So we have a very broad perspective. So this is a bit busy, but our central activity is the case control studies. Across the 3 sites, we have over 1,000 cases and 1,000 controls to date. We have a very detailed questionnaire, which is for those settings. So it was kind of designed before the Mutographs, and there's only a subset of that data going to the Mutographs. And if it's useful to get more of our local specific exposures to help identify these mutation signatures, that would be great. We do a lot of side work, for example, if validating whether hot tea really is that hot, cross-sectional studies of what types of tea are very hot, why is it very hot. We collect blood and tumor, saliva for GWAS in the US. So it's the cases that are coming through in the questionnaires that are feeding through to the Mutographs program. We didn't have tumor and blood samples on all, so there aren't 1,000 cases coming through to you. But I think by now probably a few hundred have come through, and the success rate is unfortunately not amazing at the DNA extraction level, and partly because of it would be great to get more training locally in the technical aspects of getting biopsies. So this is in West Kenya. That's the Moi Teaching Referral Hospital. This is the endoscopy unit, and that's a patient undergoing endoscopy. This is none of the endoscopies are done with sedation in the setting, which doesn't help the quality either. In Tanzania, we work around the base of Mount Kilimanjaro, so this is Africa's highest peak. It's got a high population density all around it because it's a very fertile region. And these are, for example, a scattering of cases from all around the mountain. And in Blantyre, in Malawi, we're working in Blantyre. Malawi has Africa's highest incidence rate of squamous cell esophagus, and in this hospital, they're diagnosing 250 cases a year. It's amongst the top 3 cancers there. The histology is squamous cell, and I think we'll struggle to get many adenos for you, Paul. But, and it's occurring in the middle and lower esophagus predominantly. We do see amongst the case series, these are not population rates, but amongst the cases of quite a different male to female ratio across the settings. In Malawi, slight male excess, 2-to-1 men to women in Kenya, and 3-to-1 in the Tanzanian setting. And I think that in Sergei's presentation yesterday, he saw that higher, a greater proportion of the alcohol signature in the Tanzanian compared to the Kenyan, and this is kind of what you'd expect from the exposure data due to alcohol exposures, and it's probably explaining why in that northern Tanzanian setting we're seeing more men. The area is known for its alcohol consumption. There's consumption of a low alcohol brew that's 3 or 4%, but drunk in huge quantities. The container you receive is 1 or 2 liters. And there is also there are also spirits that are distilled, and these can be 50, 60 and above proof. We do see in Tanzania about 15% of our cases have hyperpigmentation of the lips because the spirits have actually burnt out the pigmentation. So this kind of enriched exposure data where you will have no exposure misclassification in these small subsets would be, I think, quite informative. So we should talk. Africa has a particular, something that's not common to the Iranian and Chinese high incidence areas. We have very young patients, a consistent small proportion of young patients. So particularly in Malawi and Kenya, less so in Tanzania, but in Tanzania we see more older patients because we're actually going to the rural clinics. And the further you go into the rural clinics, you're getting patients in their 70s and 80s. So the lower proportion here is probably because we see old patients that we're not seeing here. I don't know whether some of those young patients are either they don't exist or are they bypassing that setting and going straight to Dar es Salaam. But these very young patients, it might be worth an extra effort to ensure that we're getting good tumor quality when we do get these patients. Even in their 20s, we consistently get patients in their 20s every year. And what is driving their risk, we really don't know. So the current etiological model that we're thinking about is that actually in Africa, this is a geographically defined region of high incidence. It spans very different genetic groups from Ethiopia down to Malawi and possibly Zimbabwe and Zambia. And it really hugs or it's in proximity to the Rift Valley, which we find intriguing. Even within Ethiopia, it's in RC and Bali near the Rift Valley. In Kenya, it's in the west near the Rift Valley. And we think that there's some dominant factor that's the mystery factor that we'd all love to know. And then on top of that, you get gender, pattern, lifestyle risk factors like alcohol, tobacco, which are easier to identify. But really, we'd like to know this mystery underlying factor. So the risk of kind of potential risk factors are exactly what Reza Malekzadeh proposed yesterday. I mean, the only thing that I think is not present in the African setting is opium. One finding, it's only ecological, one possible factor is micronutrient deficiencies, because we were struck in China, the findings that low selenium likely had a role, especially selenium supplementation reduced mortality in the Lynchen intervention trials, that Malawi, Africa's highest esophageal cancer incidence country, has 40% primary selenium deficiency. And actually the top 10 highest incidence countries in Africa do seem to have slightly lower suboptimal selenium intakes based on food balance sheets, but this really needs to be looked at an individual level. The possibly relevant there is that the Rift Valley, the soils are acidic, and the transfer of selenium from crops to humans is impeded. So it's a geological factor that's geographically patterned that may give rise to this selenium deficiency. We have finished the case control study in Kenya, and it's just 3 papers out so far. We observed a positive association with self-reported thermal injury. We've independently done cross-sectional studies, and the tea is hot. It's much hotter than in Iran. And this is because we're talking about high-altitude areas. So Eldoret is at 2,200 meters or something. And it is cooler in the cooler season in the morning. There's no central heating. It is cool, and people do drink hot tea. They enjoy it hot. We've found these positive associations with alcohol, particularly contributing to risks in men and at older ages. And I'll just go through a little on the oral health findings slightly in more detail here. On the alcohol, we're also providing tumours to Zenko's group here at IARC, and they're looking at the methylation signatures there. So oral health in Kenya, down this Rift Valley, oral health is actually, the general oral health status is actually very good, and you see beaming white smiles that are better than the beaming white smiles from the current room. But this is what you see, and I don't think it's just a contrast against black skin. They are beaming white smiles. And unlike Golistan, where there's a huge amount, and China, that there's a huge amount of tooth loss at older age, there's actually, in East Africa, there's very little tooth loss, despite the fact that there's very little dental care. The diet probably has a lot less sugar in it as well. And anyway, like everyone else, we put oral health in the questionnaire. And although the status is reasonably good, we do see the associations as you'd expect. So the less you brush your teeth, you see an increased risk. If you don't use a toothbrush, you see an increased risk. And DMFT, everyone can calculate their own. It's how many decayed plus missing plus filled teeth you have. It's just the sum of those. In this setting, hardly anyone had a filled tooth because no one goes to the dentist. But the median number of decayed and missing teeth was about 3 in controls. And in Golistan, this is in the high 20s. It's a totally different distribution, but yet it's still a risk factor. So the more missing teeth, the higher the risk. And these associations really need to be understood. But just going back to one of the pictures there of the Kenyan man, this man has a stain on his tooth, and this is dental fluorosis. When he had his baby teeth, they probably were white, because baby teeth are developed in utero, and the development is kind of protected in utero by the placenta. But when he was from age 0 to 5, and specifically around age 2, in the Rift Valley, there are excessively high levels of fluoride, and it disrupts the mineralization of the enamel on the tooth. So as children, permanent teeth erupt at age 6, 7, 8 onwards, they have this kind of symmetrical brown stains, which is dental fluorosis. At extremely high levels, skeletal fluorosis occurs. So not knowing what we'd find, we stuck this in the questionnaire and looked at whether it was related to risk. This is the grading fluorosis from none to quite severe fluorosis, and you do see this in the area. It's a real aesthetic problem, and people are kind of smiling like this and covering their mouth. And this is what we found for esophageal cancer risk, adjusted for alcohol, tobacco, education. And the control prevalence is 8% moderate to severe fluorosis, which is what you'd expect in the population, and this is what we found in the cases. We've since looked in Tanzania. We don't have quite so strong an association, but it's there, going up to about 5 or 6-fold increased risk. When we tried to look at different subsets, under age 50, over age 50, men, women, whether you drink or not, even though our numbers just in this Kenyan case control study were not massively strong, we couldn't really shift this except if we stratified by your number of decayed or missing teeth. And it seems like that if you've got moderate to severe dental fluorosis that leads to decayed or missing teeth, we have this super strong increased risk. This really puzzled us for a long time, like how on earth would exposure that occurs when you're 5 years old be related to your risk? And our average cases are about 55 to 60. What on earth does this mean? And I think we need to kind of get behind this. My current feeling is that it's perhaps the damaged dentition is leading to a altered oral microbiome later in life. So it's not the exposure, or the exposure leads to a damaged oral microbiome later in life. But we need to really investigate this. Why we think this is kind of intriguing is because the area of excess fluoride, the fluoride belt in Africa, is nearly the esophageal cancer belt in Africa. Now, fluoride at excessively high levels, and they're excessively high, they're way beyond safe limits. There are areas in the world that have excessively high fluoride levels and dental fluorosis, and they have no esophageal cancer. So we're not pointing our finger at fluoride. There could be other properties of the water. There could be alkalinity of the water. But this needs to be done. We really need to go back to the cases and controls homes and get water samples to see what's in there. So that's the kind of emerging picture. We have a lot more work to do. We hopefully will close the case control studies sometime next year, but we're really looking for funding to go back to the homes and get water. I mean, unpiped water is a risk factor in Iran, China, and Kenya, but this is not specific enough. I mean, there's so many populations in the world that have unpiped water. So what is it about the water that's conveying the risk and the areas we'd like to go down? So just finally to thank the teams. The teams in each site are very large. So Diana Menya, Charles Amalala, Blandine and Baga are leads. And I'd also like to thank Stephen Carew-Romena, who analysed most of the oral health data under a UICC Development Fellowship here at IARC last year. And finally, I leave you with a lovely picture of the Rift Valley. Thank you.